So for me, there are distinctive time periods. Primary graft dysfunction, non-function is really in the first 48 hours. You're relisting the patient and trying to get them transplanted. You can expect survival if you get a graft early of between 30 and 50% with these patients. Then you have early graft dysfunction, which becomes apparent by day 5 to 7. You've really got to have made up your mind whether or not you're going to offer retransplantation, I think, by day 7, because after that, it's really getting late and the outcomes of retransplantation are often less satisfactory because by that time, patients may be becoming septic, they're getting changes with multi-organ dysfunction that precludes successful transplantation. For DCD, DCD is quite different from DBD, liver transplantation, in that graft loss seems to go on for much longer. And I think that's because of the development of severe cholangiopathy, which can require retransplantation up to 6 months post-transplant. Early portal vein thrombosis, I've already said, is associated with poor inflow. You'll see it in young patients with severe portal hypertension and splenomegaly. It's really important to identify this early, identify and close the collaterals either radiologically or surgically, and reconstruct the portal vein. This would be an example of a patient at risk. This is a young adult coming to transplant with their native liver intact after early Kasai portal enterostomy. You see quite clearly small portal vein, and if you look at other patients, you may see large collaterals within the abdomen with flow. If you don't identify and tackle these patients, you may have graft loss through dysfunction and not understand why. The final message is that if you have primary graft non-function, you only have one go at it. The results of redo with primary non-function are dismal and you shouldn't attempt it. And this data from this nice single center experience from Dallas conclusively shows that. The factors influencing outcome of liver retransplantation, well, I think the expertise of the transplant center, the surgeon, anaesthetist, intensivist, hepatologist are really key. Defining who should be retransplanted, trying to do this early and decisively. I think looking at risk factors in the recipient, particularly their cardiac function, is important. Looking at the donor quality for the redo, trying to ensure you have a good quality graft is also important. And surgical practice, your technique has to be really of a high order. There's this paper that was published recently in Nature Communications, which was looking at other models of early graft failure, trying to identify who should potentially be transplanted. This has opened a whole series of new models. And again, Dr. Reddy has looked at one of those. All of these are trying to model continuous graft function over the first 7 days to try and see which patients appear to be improving and which are stuck or deteriorating, to see if it's possible to offer patients early retransplantation. All of them require algorithms that you calculate and get a score. I think they're helpful, but they're quite complicated, but they are the way that things have to go. And you can see here in the L-graft score that it is quite useful, shown here on the day 7 score. It does start to separate out patients with liver graft dysfunction and may help in terms of decision making at this important time in deciding which patients you will or won't offer liver transplantation too. So this is a field that's moving forwards, and although complex, it's trying to help guide management. So just to summarize, really, I think it's important to recognize early graft function. The surgeon can recognize it by the patient being stable hemodynamically, early production of bile, lowering of pressor requirements, and a falling lactate. Getting hemostasis is an important step in recognizing graft function. Recognizing early graft dysfunction is the opposite, a rising lactate with a low blood glucose. Beware a rising lactate with a high glucose. It may be that the patient needs more insulin and the lactate will start to come down. Hemodynamic instability and pressor requirement. It's important to try and get hemostasis to help the anesthetist manage that instability. Recognizing when there's a coagulopathy and it's not just the anesthetist failing to manage it properly, and for the surgeon failing to gain hemostasis because of suture deficiency. Identifying early high ASTs, and again for me the threshold would be on that first day an AST of greater than 10,000 would start to make me think about early relisting and transplantation. So by 36 hours, the lactate should be less than 2. Really try and understand what's going on with the patient at that time. It's a time to focus, identify any problems, resolve them. The ST should be halving after day 2. For DCDs, the AST will come down sharply on day 2 and 3. And as say the day 5, 7, the 50-50 and Althoff criteria with a serum bilirubin of greater than 170 and an INR of 1.6 clearly identify the patients at risk. And those patients are going to go on to get further problems. The AST never normalizes. It remains around 150 to 200. This for me is not reassuring. These patients are at risk. They may get septic and decompensate. But what I would say is retransplantation has to be performed within 10 days. Otherwise, you're really looking at patients who are at high risk from retransplant, usually because of underlying sepsis. Thank you.
Thank you very much for a wonderful talk, Prof. As always, mesmerizing. And you covered all extensive experience with your talk. These things are very useful, especially in Indian scenario, because where cadaveric transplant is becoming rare and less frequent. And when to accept the liver is the crucial point in India. So you touched all the points, Prof. So questions, shall we take after the case or before?
I think let's take them after the case.
Okay.
And then we can talk and maybe contrast that with living donor and the experience that's been reported.
Sure, Prof. Okay, let me invite Shruti Reddy, who is going to talk a case on early graft dysfunction after DDLT. Shruti Reddy is qualified from prestigious AIMS in 2018. Then she started working at Senior Clinical Fellow for past 2 years. She's going to talk about this case. Shruti.
Thank you, Dr. Rashmi. At the outset, thanks, Prof, for the invite, and thanks for the team for having me here. Let me start my presentation. I hope I'm audible and my slides are visible.
Yeah.
Okay, thank you. So after those interesting talks, let me see if I can bring out the multiple factors that went into early graft dysfunction in this case. This was a DDLT which we had done in King's some 4 months ago. So basically, the recipient was a 45-year-old lady who underwent a transplant for vascular liver disease. She had portal vein thrombosis and non-cirrhotic portal hypertension, as you can see from the images here. There was no underlying hematological disorder. Her first presentation was with varicose bleed 7 years ago, and she was listed for a liver transplant 3 years ago with decompensation in form of synthetic dysfunction, ascites and hepatic infarction. At that time, she was child C and Meld was 21. Over the next 3 years, she did not receive any liver offers on our allocation system. And she had multiple hospitalizations, mostly infective complications and GI bleed. In July 2021, she had admission with us for GI bleed again. This was from a portal hypertensive gastropathy and gear. This was managed with endotherapy. She also had hepatic encephalopathy and AKI at that time. Her child score was 10 and Meld was 20 at that time. But seeing that she's not getting any better, we listed her for extended graft treatment, that is CCD and extended viral grafts. During her hospital stay over the next few days, her bilirubin progressively rose. It went up to 800 mics, that's almost 50 mg per deciliter. And she also became septic with blood culture positive for streptococcus, and she had to get admitted in the liver ITU. So this is the trend of bilirubin. As we can see, her baseline bilirubin has always been in hundreds, and over 10 days, it went up all the way to 900. She had 5 organs which were dysfunctional: liver, kidney, brain, coagulation, and circulation. And given all of this, she was prioritized on the allocating scheme. At that point of time, she had a MELD of 37. She qualified as ACLF grade 2. So after prioritization, she received the graft, a DBD graft. The donor had suffered a hypoxic brain damage after a cardiac arrest. The downtime was 30 minutes, and there was transaminitis prior to after the arrest, but then it had come down from 500 ALT to 100 ALT. And given there was no other risk factors, we felt this to be a good donor, or we accepted the liver for this particular recipient. The donor was 50 years old, and the liver weight was 1.8 kilos. It was non-fatty, and the cold ischemia time came up to almost 11 hours. The portal vein required aversion thrombectomy, and implantation was standard piggyback implantation with 2 hepatic veins. And in this particular case, we also had to do splenic artery ligation and shunt ligation after the reperfusion. The reperfusion itself was uneventful, but given the complexity of the surgery, there was 15 liters of blood loss. We routinely use a cell saver, so 2.5 liters was salvaged, and she required multiple other units of blood transfusion. The peak lactate was at the time of surgery 6.8, but what is to be noted is there was no inotropes which was required after induction. But then the main problem in this particular case was coagulopathy, in that there was generalized disease from all the raw surfaces, which did not get controlled even after multiple rounds of hemostasis, and this required packing. So she was shifted back to the liver ICU after packing. On day 0, there was ongoing bleed and rising lactate, and she was re-explored the same day. There was some collected blood and diffusion, but then the liver appeared soft at this point in time. This was approximately 6 hours after shifting her back after the first transplant. Biopsy, which was done at this point of time, showed severe preservation injury and extensive parenchymal necrosis. So this is the biopsy, which is showing some perivenular necrosis there, and this is C4D staining, which is positive. So as you can see here, this is when she had the transplant. The lactate progressively rose, and the AST peaked at 5,400. So after the first re-exploration, due to ongoing bleeding, we decided to do a CT. On the CT, we noticed that there was still some clot. Yeah, there was still some clot, and we had repacked during the first re-exploration. What we could notice is the right posterior sector and parts of the periphery of the left lobe had suffered some ischemic damage. So on day one, we had to re-explore again. At this point of time, the liver was edematous and there was patchy ischemia in the right posterior sector. Biopsy again showed perivenular necrosis. This was in keeping with ischemic type injury, which is unlikely of any hyperacute rejection, again, which is shown here. So, given that she was hyperlactatemic, despite putting her on the filter, AST was high. Her coagulopathy was not fully controlled at any point of time. She was continuously bleeding. We decided to list her for a super urgent renal transplantation. She received a second liver on day 2. At this point of time, we noticed that the liver had bilobar ischemic patches. And there was a second factor that we had in mind, that there might be portal vein hypoperfusion, as we discussed in the previous discussion, because she had a thrombus which required thrombectomy, and there was multiple shunts. Despite us ligating the few, there were still a few more shunts which we could not ligate. So we measured the portal pressure initially, it was 16 millimeters. But then the subjective assessment of portal flow on dismantling the previous anastomosis was found to be okay. So the second liver graft was again from a DBD donor who had intracranial hemorrhage. This was a 30-year-old donor. The graft was non-fatty and it was 1.9 kilos. Post-implantation, we measured the portal vein velocity with Doppler. That was 14 centimeters per second, and the portal pressures was 11 mmHg. And everything itself improved. The TEG parameters improved, and we decided to close. From this graph, we can see after the second transplantation, the lactate progressively came down, and so did the AST. The histopathology of the explant liver was, macronodular cirrhosis, but then that of the allograft was broad ischemic necrosis of the liver, with approximately 20% of the parenchyma being necrosed. And there was severe cholestasis of the residual parenchyma and cholangiolar bile cast. This is probably suggesting of sepsis. C4D staining was positive, but then impression of the pathologist was the pattern of necrosis is in keeping with ischemic type damage than anything else. This is the gross image. You can see necrosis, ischemic damage in the right posterior sector and parts of the left lobe. The same in histology, perivenular necrosis and broad areas of necrosis. And these are the cholangiolar casts, probably because of sepsis. So post-transplant, the first month after transplant is quite stormy. She required support, respiratory support, and renal support. There was ongoing sepsis. There was elevated BDGs. There was cholestatic LFTs, but overall, she recovered out of the graft failure situation that she was in. And her late post-operative period, which is ongoing, she's still admitted with us. She required multiple ICU readmissions because of pneumonia and seizures. She's having multiple neurological complications despite taking the standard measures like CNI switching, etc. She's having some psychological issues now. The cholestatic LFTs, which we had noted after the second transplant, is currently resolving. But then the current images are still showing significant photosystemic shunts and some portal vein narrowing. So this portal vein narrowing is non-progressive, but then the shunts are very much there. And the impression of radiologists is that they might still be shunting a significant amount of portal venous blood into the system. So this one is possibly for a IR guided management in the next month. So in summary, this was a 45-year-old lady with vascular liver disease. She was sick going into transplant. She had ACLF. She received a good graft, or may I say borderline graft, given that it was from a hypoxic vein injury donor. The surgery itself was complicated. there was early graft dysfunction manifesting as cardiopathy and retinopathy. There was ischemic injury to the graft as well. Whether this was contributing to graft dysfunction or whether this was a manifestation of graft dysfunction is something which needs to be debated. Probably there would be a component of both. It was salvaged with liver transplantation, and there are ongoing issues in this area. Thank you.
Thank you, Shruti, for a very interesting case. Clearly depicts the complicated early graft dysfunction and PNFs in DVDs. So let us, Prof, let us welcome Dr. Sadil and Weil Jassam also for like a discussion that's separate. What do you think? Yeah.